accessing the YouTube connection platform. Shall we start, Professor Maria Helena? Yes, please. Okay, then. Ladies and gentlemen, good morning. Welcome all of you to the International Webinar, Management of Human Resources in Health and Emergencies, promoted by the School of Nursing in Ribeirão Preto from the University of São Paulo, Collaborative Center PAHO, and WHO for the development of research in nursing in partnership with the technical unit of health service units and human capacities for health from PAHO Brazilian office and with the Secretary of Labor Management and Education and Health from the Ministry of Health. This event is broadcasted by the channel of the School of the Nursing channel on YouTube on Portuguese and on the Innovation Portal in Spanish. For the opening of this event, we'd like to invite Professor Dr. Maria Helena Palusmad, Director of the School of Nursing in Ribeirão Preto from the University of São Paulo, Dr. Marli Cho, Regional Assessor of the Unit of Human Resources in Health from PAHO, Washington, D.C. Marcelo Marques de Lima, Technical Assistant of the Department of Management and Health for the Secretary of Labor Management and Education and Health from the Ministry of Health. With the word now, Mr. Marcelo Marques de Lima. Good morning, everyone. Good morning. I'm very happy to be here participating once again through the invitation of Maria Helena and the team of the project. I apologize on behalf of Vinicius Nunes Azevedo, the director of the department. We've had a change in the management of the Secretariat these days, and we are restructuring ourselves as institution to continue our work and to close the cycle of these 4-year management cycle. I believe that the topic which was put into evidence in this pandemic was the need to have a little bit more of care with human resources in health when we talk about public health emergencies and when we tackle emergency situations. I believe that the guests and the participants in this agenda will contribute so much. I think it's going to be a very interesting exchange of experience. I hope you all have a wonderful morning, and that's it. Good day, everyone. We'd like to hear now Dr. Marli Cho.
Good morning, everyone. I believe that this morning here in Washington, it's a very beautiful morning after a few weeks of severe cold. So before anything else, I'd like to thank Dr. Maria Helena and the entire team working on the organization of this event, the Nursing School of Ribeirão Preto from the University of São Paulo, the Ministry for Health, and the Secretariat of the Management of Labor and Education of Brazil, and all of the colleagues on this panel with very interesting lectures, everyone with a lot of renown and experience, and everyone who's going to share the discussion. As a representative of the Pan American Health Organization, PAHO, from Washington, and also in the Brazil office, for us, it's truly a pleasure not only to participate, but to know that there's a group and a team of people who work to support, contribute, and come up with studies and research about the risks of healthcare workers, either in terms of a pandemic, something that we're going through, but also in our everyday lives, in our work. For us, this participation is truly important, and I'm very thankful to have this space to be able to share. So thank you very much for that.
Passamos a palavra à professora doutora Maria Helena Palucci.
We pass the word now to Professor Maria Helena Maziari. Thank you all. Good morning. It's a huge pleasure to have you here with us this morning. Dr. Maricho, well, Ribeirão Preto is a very hot city, so we have a lot of sun and a very interesting environment. So I believe that is well, the environment also interferes. So as we are here remotely, each of us in our part of the world, here we are connected into a project, a unique project, which is focusing on the life quality of everyone, and in our case, the health professionals, which are tackling and facing the pandemics bravely, but they also have risks, and these risks must be controlled, identified, and our project, AGIR, is born with this idea, with this role, and this objective, and we had a partnership during a year together with the MOH and with PAHO, and mainly the team of PAHO Brazil, which supported us in this fight. And we could have lots of achievements in this period. And in this seminar today is one of the products or the results of this project, which is the assessment and risk assessment of professionals of health in COVID-19 context and health units in Brazil and possible outcomes. So we are going to have today speakers that will give us presentations, international presentations on how the international context is focusing on this matter of human resources, but also facing not only people, but also the management of the people. We are going to have in our schedule or agenda also the results of those studies that we performed during this year, and tomorrow we are going to see those results, which have as an objective to expand the discussion over those risks, over the ways that we could manage those risks, mainly those that are managing the services. On one end of this interconnection with the population. So, what we would have here is the kickoff. I believe we're just in the initial phase of the pandemics, but it's the start or the beginning of new perspectives, let's say. So, considering this work, we hope to continue together with other people also collaborating, supporting, and bringing new results and outcomes so we could be facing not only this pandemics, but also others with more control, lower risks, and less number of illnesses and deaths. I thank you all for your participation here on behalf of Dr. Marley Chu, all the speakers, and on behalf of Professor Francis Colano, which is with us through Google Meet, all the authorities as well, participating with us in this discussion, in this debate. Those of you that are connected to us on YouTube, we hope that you can, through the Q&A, interact with our speakers so we can deepen these discussions and debates, and certainly we're going to have a very productive and positive day with all of these presentations that were selected and chosen, trying to see the specificities and the quality of our speakers. So we thank you all for this collaboration. So let's continue with our agenda. Thank you very much, everyone. So in this moment, the opening panel is concluded, and we invite Professor Dr. Carla Aparecida Arena Ventura to take the coordination of the first of the panel, Management of Human Resources in Health and Health Emergencies. Professor Dr. Carla Ventura is a professor in the Department of Psychiatry, Nursing, and Human Sciences for the School of Nursing in Ribeirão Preto. She has experience in the areas of health and global nursing, international law of health, international right of health, and protection of international rights for human rights, bioethics, legislations of nursing, mental health and human rights, participation in social control and the rights to health, diplomacy in health and nursing, public administration, and systemic methodologies. Since 2017, she is the director of the Collaborative Center for PAHO, WHO, for the development of research in nursing. We inform the participants that you can be sending your questions to the speakers during the presentations using the chat in Zoom. Professor Carla Ventura, the word is yours. Thank you so much, Damara. Good morning, all of you here with us. On behalf of Professor Dr. Maria Helena Palucci Maziali, I'd like to greet everyone here present, and I'd like to deeply thank the organizing committee for this relevant event, for all the trust in giving me this responsibility of the coordination called Management of Human Resources in Health and Health Emergencies. In this panel, we are going to count with the presence of 4 speakers, which kindly accepted the invitation to participate in this event and share with us their knowledge and experiences around this topic. After their presentations, we are going then to have a debate moment for interaction and discussions. The speakers will have 30 minutes for each presentation, and when we have 5 minutes left to conclude the 30 minutes, I will open my camera. I also would like to invite you all, as Professor Damara just mentioned, to share your questions with us and participate using the chat. So we're going to start with Professor Dr. Mali Cho. Dr. Mali Cho is born in South Korea and nationalized in Paraguay. She obtained the title of a doctor in medicine and surgeries from the National University of Asunción in Paraguay. She is an expert in biology, master in administration and management of companies, business administration, and development and analysis of projects, a master in public health, and a master in health economics. Dr. Mali Cho, the positions of coordination and management as a lab leader of histocompatibility and transplants for a hospital Paul Rousseau in Paris. Dr. Mali Cho also, just a second please. Sorry. Dr. Mali Cho also worked as the director of the blood services in the National Hospital of Paraguay, as the assistant of the public health ministry for blood systems in Paraguay, as a consultant for IDB for a project of health for women, children, and boys in Paraguay. Girls in Paraguay, besides developing and participating in national policies in the different areas. Health service systems in several countries. From 2005 to 2010, she entered the PAHO and WHO as the assistant for blood services. After that, she took the position of regional consultant in health and safety for the patient, consultant of safe systems and currently she's the regional consultant of human resources and health based in Washington, D.C. Thank you so much, Dr. Malicho, for being here with us today. And she will talk about the management of human resources and health, tackling COVID 19, global strategies which were implemented. Well, the word is yours, Professor Malicho.
Thank you very much once again, Carla, and all of the team. I was trying to share my screen. Let's see if I can manage to do that now. I believe you can see it, right? Is that working? Can you see it? Yes. Yeah, if you could just put that on presentation mode, full screen.
Right, you just need to put on presentation mode.
All right, I think you can see it now. Yes? Is that okay? Yeah, now it's perfect. Thank you, Dr. Cho. All right, so once again, thank you very much for this space that I'm sharing with you. I'd like to present with you on a very short time the work that was done about how the management of healthcare resources was done in view of the pandemic. At first, we thought the pandemic was going to be something relatively temporary. However, we've been at it for more than 2 years, and we are still facing difficulties in terms of healthcare resources and human resources to face the pandemic. So I'd like to give you an overview of what is the situation of the pandemic at this time. This is a screenshot that we've done in the beginning of February, in which we see that globally, at this time, we have more than 383 million people who are confirmed cases of COVID. And we still need to include here the ones that were not confirmed. And I'm saying this because I had all of the symptoms for COVID, for example, but I did not go through a study to confirm that because I had done that a week before I traveled. And after I arrived, I had all of the symptoms. So I did a quarantine, I remained on lockdown and did all of it, but without having a test to confirm. And that implies that these numbers are much higher. And of this group of people who are confirmed cases, we have more than 5 million, or almost that, 5,700,000 people who passed away from this disease during the pandemic. What is something that leaves us hopeful is to have an increase in the number of people who have been vaccinated. And at this time, we have more than 10 million 766 people who have been vaccinated, and this number keeps growing. In a certain way, what this slide shows us is the amount of people who have been infected. As you can see on the graph, and as the curve shows, the region that has the highest number of infected people is in Europe, followed by the Americas as a region. However, when we look at this graph, looking at the mortality numbers, the number of people who were infected by COVID, we see that the region of the Americas has the highest number in regards to the other regions. This is a curve that shows that since the start of the pandemic, as you can see on the graph, everything begins approximately in January 2020, and the pandemic was announced during the first weeks of March 2020. And we can see a start of the amount of infected people and deaths that just keep growing on the graph. What's interesting to see is how in a certain moment when we start to have vaccines and these vaccines start to be used more and more, the mortality curve starts to decrease. However, you see the different mutations, and this makes the return of peaks once again. What's interesting about this is that in the last few months of last year, the mortality curve had lowered a lot. And this implies once again that the load on healthcare services was a bit less, but unfortunately, the new Omicron variety in the last 2 months that made that caused a peak on the number of cases that you can see on the graph again. What we can say, and this is important to think about, this is a publication by the World Health Organization about the impact of the COVID pandemic in healthcare workers, and looking very closely at mortality, because you know that the official reports on the mortality, that's relatively very low. It does not go beyond 10,000 deaths globally. So what we did in terms of the World Health Organization is an analysis. It's an analytical approximation of different estimates with respect to the amount of infected people regarding the percentage or the mortality rate in different groups. And what we could get in terms of projections of the possible deaths in healthcare workers between January 2020 to May 2021 was an estimate of approximately 115 this number of healthcare workers, 115,500 deaths with a range between 80,000 to 180,000 deaths. As you know, COVID affected in a multidimensional way. And this multidimensional affection, let's put it that way, on healthcare workers, we can see in a certain way, we can have a scheme about it. We can see how it affects healthcare because of the infection, because of the deaths, because of stress, because of burnout, and all of these mental disorders that also were very strong. At the start of the pandemic, we had social and well-being effects because of stigmatization and the discrimination of healthcare workers. They were affected by this because of the society. Despite everyone thanking those healthcare workers, claiming them as heroes, they did not want them around, and they did not want them close to people's homes. So there was this discrimination because people were afraid of being infected. And also socially, it was necessary to have other roles for them in addition to their work. They had to care for family members. Additionally, we had effects on working conditions. I'm sure you saw globally all of the demonstrations and protests. First of all, because healthcare workers felt that they were not protected. They did not have the personal protective equipment and the materials. They did not have the necessary knowledge about how to manage the pandemic. That was very much limited. They needed protection also in the environment, and they need to know how to avoid such violence, because I'm not sure if this happened in Brazil or not, but we had cases of healthcare workers who were harassed, and people became violent with them because there were no places in the hospitals, and family members were very aggressive, and they demanded attention and hospital beds for their family members. And we can also understand that looking at the other side, they had their reasons, but we need to understand that the healthcare workers gave a lot of themselves, and they went beyond their abilities to do everything that they could. Another important component is how to manage all of that, because there was a limitation for healthcare workers. They had a lot of things to do, and so we needed to think about how to fill those spaces and those gaps, and who were the ones who were going to work on that. And of course, we had COVID-related absences that had to do not only with the group, with the important, significant percentage of people who had to leave work because of their age and risk factors, but also because those people needed to care for family members who were ill. This is a study that's very much regional, and it has to do with the impact that COVID had on human resources for healthcare and the political actions that took place in 5 countries of the region: Bolivia, Chile, Colombia, Ecuador, and Peru. What's interesting to note here is the rate of mortality, the variability of the mortality rate for these healthcare workers. And that deserves an in-depth study, but in a certain way that also reflects the ability of the sanitary institutions, the healthcare institutions, to provide good working conditions and also to have proper management of human resources. On the other hand, it's also interesting to see this curve over here. It shows that in the beginning of the infection curves between the general population, which is this one, red, and the infection curve between healthcare workers in yellow, they were virtually very much similar. They were parallel to each other. We need to remind ourselves that healthcare workers at the start of a pandemic, there was a significant difficulty to have personal protection equipment due to not only local issues, institutional issues, but also the reduction of the production of these materials and equipment, because at this time, 80 or 90% of this material was imported. And when the pandemic was announced and the sanitary measures were taken, of course, all the production activities and manufacturing activities were reduced, some were closed. And we also need to think about the fact that transportation was seriously affected at the time, and the distribution and assignment of these materials were also affected. But what's interesting to think about is that when we start to have in January approximately, January 2021, the end of 2020, start of 2021, the availability of the vaccine, you can see the reduction of that between healthcare workers, especially because we had a policy that was being applied on that the population that was going to receive the vaccines first should be precisely healthcare workers. In this graph, what we can see is the infection that we see with healthcare workers, and that is in yellow, and the general population here in red. And that clearly shows that in effect, you have female population that was affected, that was much more significant than the male population in healthcare workers. This is not just a reflection of the feminization of the healthcare professionals. Approximately 70 to 75% of healthcare workers are women. Of course, the age of is much more important in terms of infection. People who have who are on the front line and those who are active on this work, that was much more significant than the ones who were removed because there was a risk of contamination. This is not equally reflected on the general population, in which the infections are basically equal in terms of men and women. This slide shows the mortality, and this mortality, we know that it was much higher on people who were a certain age and older, but we know that it is much higher in men than in women. And this is also reflected on healthcare workers and the general population. The percentage of the mortality for men, here we can see that it is much higher than what would be seen for women. The same thing is here for the general population. The theme of healthcare workers, this was very much discussed with this reorganization of the healthcare systems and services and the need to fill the gaps that were created. And the World Health Organization declared the year of 2021 as the International Year of Healthcare Workers. And the motto was these 3 points. The one to protect is to protect, because one of the most serious problems that we saw at the start of the pandemic is the need to protect healthcare workers as essential elements for health, and not only for the health, but also for the society as a whole. And also the need to invest. And to invest does not mean just to invest in wages, but also to improve working conditions and also to improve compensation and to look at the incentives that can be financial, but in addition to the financial incentives, we have also non-financial incentives that influence as well. And we all need to work together for that. When we analyze what was the scenario, however, before the pandemic, and we look at the purpose number 3, objective number 3, between the Sustainable Development Goals, the SDGs, before the pandemic, we knew that there was a deficit for 2030 of more than 18 million healthcare workers. And this affected low-income countries especially. What we can say is that as a general context, the pandemic, what it did was to show very clearly those themes that we knew they were recurring themes. And they also, they returned a lot in terms of healthcare issues. And up until this point, there was no proper response. There was no possibility, or at least we used to say, countries and governments used to say that really it was very hard to work with that because, in effect, when we go deeper in healthcare, human resources, that's a theme that it's not just a sector that can provide the answer. It's not just the investment of a sole country in a sole sector that can answer to this. A lot of sectors are involved. Healthcare sector is involved, which is the one that manages the human resources. But also we have the intervention of the education sector that needs to be aligned with the healthcare sector so that it can produce, it can come up with these human resources that are adequate and that are skilled at this attention model that this country is looking for. We saw that there's a need to have sufficient numbers, but especially that they are properly assigned and distributed and that they are committed and prepared, because this commitment is very important in the sense that poor contracts with a lot of human resources, a lot of healthcare workers, when there are poor contracts and working arrangements, you see that they are in a risk situation because they say, why am I going to put my life in risk if the institutions are not acknowledging me as a professional and as an essential worker? So to be able to have this commitment, we need to revise and update all of this to work on this institutional commitment with the healthcare workers so that they can answer on equal terms. We also had a reassignment of human resources due to the increase on the needs to have more personnel for ICU. This was in the beginning of the pandemic, in which practically all of the countries in the region started to increase numbers of beds and respirators and equipment on the ICU, and we needed a group of people who was trained to work with this equipment, and not everyone is able to do that. But at the same time, as time went by, and since the pandemic lasted much longer than what we thought, because we thought that after 2 or 3 months that was going away, but it didn't. We saw that we needed to change the responses to the needs of healthcare of the population. And the best way to be able to respond and to keep the health of the population is to have this attention. And of course, that we saw that there was a sub-investment that was chronic in everything that has to do with human resources in healthcare. There were many innovations to provide answers to the challenges since then. In healthcare systems, we had more investment. A lot of countries started to come up with funds to improve and to increase the number of workers. I always used to say at this time that with money at this time, that's how we can manufacture these healthcare workers that are trained. We can't just do that. This takes time. We need to have more long-term investment, and we need to have planning as well, long-term planning. There were mechanisms to protect workers. We had monitoring, vaccination. In a few countries, we had legal protections for these workers. There was an acknowledgement of COVID as a professional disease. So there was a reorganization of the tasks. And in a certain way, we also provided assistance. There was an assistance to mental health because it affected healthcare workers too. There was a quick compilation of information at this time to be able to calculate the roles and calculate the number of funds, and that's also something that we needed to see. We also had an articulation with the educational sector so that the professionals who were studying, we could put them to work in a quicker manner. And we also had students who were on the last year that they started working in a few things as well, and also with a community approach. What is interesting to see as well is how we had the implementation of innovations. Digital tools and telemedicine, that's not something that came up with the pandemic. That was something that already was already around before, but it was difficult to incorporate all of that in the structure that was already established. So to make that change, it was hard. And there were a lot of difficulties in the years before the pandemic. I remember 4 or 5 years ago when we started talking about telemedicine and e-education, there were people who were very much against all of these changes. However, the pandemic made everyone do it, and everyone needed to work with this mandatorily. There was a quick mobilization of human resources. And in this sense, I believe that human resources for healthcare workers, they were there to adapt to tasks. They also needed to update everything, how people work. But this needs management, it needs structure, it needs an institutionalization. It's not just at a certain at a given moment, you can just provide the adequate answers. So this is something that needs work. And also we had contractual arrangements, a lot of contracts, unfortunately, that were temporary agreements for healthcare workers, but we had others as well. Training and generation of competencies, that was critical because, as you know, COVID was a relatively new disease. And I say relatively because we already had information of a similar virus, H1N1 and all of that, but it behaved differently. and it needed to be updated. And you are testimonies to all of the controversies that were around about how it was transmitted, if it was by air or not, or other things, and if there were equipment for that or not. And so we needed to accelerate all of that training. And there we had an increase, an exponential increase of courses and seminars and workshops and these online conferences. And to participate in all of that before, there was a cost, not just a financial cost, but also time. But this became free and online, and that facilitated the expansion of knowledge and the availability of knowledge as well for a lot more people. And from APAHO, we had this virtual field of public healthcare, and that launched a lot of courses on COVID, and also the World Health Organization Academy and the Open WHO. They also offer courses in many languages, not just the official languages. So when you look at the different courses in all of the languages and non-official languages, as I said, in very faraway countries, this is very encouraging as well, this ability to reach this population that is so far away. And what we also believe is important is that the institutions, the education institutions for healthcare, they need to work on curricular adjustment. They're already doing that, but they need to work on that. And another thing is that we still have digital gaps that are very significant in these institutions, and especially for the users, because if we want to reach the users with digital information, we need to have this excluded population. We need to have them get more access to all of this. We also feel very encouraged because if at first, when the increase of courses took place, we were very happy in 2018, 2019. We believed that we had a lot of courses and we had more than 1.5 million users. But in the past few years, these numbers, they quadrupled. They were 5 times there. And now we have 3 million people approximately registered in all of these courses. And it's interesting to see the profile of users. So who are the ones who are taking the courses? You have a group of nurses, we have a group of general practitioners, physicians, and also healthcare students. Despite all of that and all of the challenges that are on the table and that and for which we need to provide answers, we also need information systems. They need to be updated, and especially they need to be unified, because we saw that the countries have a lot of information. They had a lot of data, but they are very much fragmented. And it's important that countries manage in some way this information, because we need to see if the human resources are active, if they're not, if they work on the area, if they don't, where they are, and what tasks they are performing. The great challenge that we had is the percentage of personnel that was separated, because there was a need to have this 30 percent of people who were removed because of risk factors or the age. But at the same time, this makes us think, if we separate 30% of the people because they need to be separated because they have risk factors or age, we need to plan for that in a medium and long term. We need to think about the 30% of people that are going to be replaced, for these people who are also going to be retired. So this is a question that needs to be answered. We also had a significant percentage of people, significantly, this affected a lot on last few months with the new Omicron strain. There was an infection that was not so serious, but it was massive because virtually everyone was infected. And I'm included in this group. And quarantine was necessary, and so much so that many countries reviewed what type of lockdown they're going to do and for how long, because otherwise there was no possibility of responding to healthcare needs. Another very important challenge was precisely this low possibility of having human resources. Thinking about the fact that hours needed to be expanded and shifts needed to be doubled, this increased not only tiring of people and burnout and also psychological disorders, but also the quality of attention, the quality of the job that was provided, and the risks and the quality of the attention and the possibility of mistakes were real. And we also need to remember that you have multi-jobs, people who leave an institution, they go to another institution, and this has a double effect on both institutions, and the person might be infected, and the risk of taking the disease and having that transmitted to another institution, that's also significant. And this presents us why, with many questions, why there are multi-jobs, and how can we act to avoid this type of situation. We also need to provide protection and safety for these healthcare workers, and we need intersectorial coordination for that. This is important as well because you know that more than 70% of healthcare workers are women, and during the pandemic and with restriction measures and sanitary protection measures, schools were closed, educational institutions were closed, and a population of children had to stay at home. And mothers are the ones who are mostly responsible for the education of the children. And since 70% of healthcare workers are women and they needed to be in their workplaces, that was a very significant issue that came up. And so we need to consider incentive policies. So how can we think about this additional work for these healthcare workers, and how can we think about daycare centers and schools so that we can facilitate the work for these women who work with healthcare so that they can feel safer and they can be calmer in their work. With respect to future actions that we can have, the regional strategy and the regional action plan, there we have, a reflection of all of these points that came up during the pandemic. So we believe that it's very important to strengthen political commitments in the countries and also strengthen the strategy to have equitable distribution and inclusion that is proper in the work, and to encourage and promote regulatory frameworks that define attributions of workers, and also to improve the offer of work for these healthcare workers, how many jobs are offered to them, and how we can have a link of this action plan with the commitment of the universal health for everyone, coverage and access. We need to think about that and continue with this process of having a digital transformation that was boosted by the pandemic. And also continuous and permanent education is very important. And I believe that leadership in healthcare sector and human resources is also very important. And so to conclude, we can say that healthcare systems of the region, they have tried to keep and increase the capacity during the crisis with results that were very valuable, and they had multiple interventions, and many interventions took place, and the pandemic showed that there are limitations in governance in healthcare systems, and there's also a persistent deficit in terms of investments for healthcare workers and social services. And if although it is a crisis, crises offer opportunities for improvement. So thinking about the opportunities, we believe that to be able to work with the different countries and think about lessons learned, that can be very significant. There's also a 30-30-30 pact that was agreed upon among all of the countries of the region for universal health, and that's more necessary than ever. And so to close, we can see that we have two groups of lessons learned and stuff that we have to work on. So first, we have personal components, which is to ensure decent working conditions, to equip those human resources with skills and competences to protect them against infection, and also to optimize job roles. And on the other hand, we have another component. It's an environmental component in this roundings, which is to ensure the assignment, and also that we have a quick mobilization of resources, and we also have policies for human resources, and that we have an increase in the investment on human resources, and that we have better and faster cooperation, especially to obtain information and to learn and innovate. And with that, I will conclude my presentation. Thank you very much for the opportunity.
Thank you so much, Dr. Mali Cho, for the excellent presentation, bringing relevant data on the pandemic effects on health workers from a perspective, a multidimensional perspective. Your speech demonstrates how much the pandemic has reinforced the need of investing in health worker resources, but also to have a cross-section cooperation and also international cooperation on the theme. Dr. Malicho has also shared with us relevant strategies and innovations implemented to health systems that are surely an important legacy to replying to the pandemic. Your speech, Dr. Malicho, has presented us with a lot of elements for debate, so thank you so much once more. Now we'll be receiving questions from participants on the chat and on YouTube. And now moving forward with our event, I'm going to present Dr. Marcelo Marques de Lima, who is a manager specialist in project management and work and health management. He has a master's in public health management from Harvard, and currently his focus point is developing projects in the Department of Workforce Labor Management, and Marcelo will be presenting management and health resources for tackling the pandemic in Brazil. Thank you so much for being here today, and the floor is yours. Thank you so much, Carla. Morning, everyone. I will be sharing my presentation with you. Can you see the presentation, guys? Yes. Yes, it's working. I think that I will go beyond the pandemic theme and deal a little bit with the responses from the Ministry of Health, lesson learned, and us as Brazil, how do we intend to restructure to be able to respond quickly to the pandemic? And obviously, we also want to continue tackling the pandemic that's still going on until this date. So the Health Workforce Resources Department, while tackling the pandemic, the Brazilian Ministry of Health has defined the strategies of Brasil Conta Comigo, Brazil Can Count With Me, which, to summarize it, it has two main goals, which were training for health workers and registration of this profession so that we're able to identify workers that are working with SUS to be able to replace this workforce that we lost during the pandemic. So tomorrow I'll be able to present it in further detail, what consists this strategy and what are the main outcomes of this strategy. But this strategic action, it came up with a lot of solutions, and us as a SUS, considering our responsibilities, Brazil has continental dimensions, but it has a very divided form, divided between the states of Brazil and how we're going to be able to deal with the situations. And the pandemic is included in that, but we're going through currently a very severe situation of flooding in the state of Rio de Janeiro, to be more specific, and in the city of Petrópolis. And the truth is that we want to be prepared to cope with any emergent situations that may arise. And then I'm going to list some fundamental factors to tackling public health. And I believe that Dr. Malichu has brought a lot of the things that I'm going to present right now, because in Brazil, these fundamental factors are not that different from other countries. The way you're going to deal with them, considering the specificity of each place. So the first one will be agility in the response. So we have contingency plans, and how this is structured is quite clear for the actors, the management actors. So this is quite important for us to be able to ensure agility in response, the availability of human resources as well. The pandemic has stressed this matter of human resources in national situations. So in Brazil, at least in Brazil, since the Spanish flu at the beginning of the last century, we didn't go through such a severe situation in Brazil as a whole. And the availability of human resources in health was quite important to be able to deal with it in the best way possible. Besides that, besides the health workers, we also need them to have the necessary abilities and training to deal with each one of the situations so that they understand how to react to each situation. And we have training centers, which were something that we also struggled with, to be able to establish this training either in person or being virtually trained. But we know that we're talking about human resources. Training is quite important to be able to attend the patient, the ability to cope with it the best way possible. So we struggle a little bit with that, because we might be able to find these places in the southeast region of Brazil, in São Paulo, Rio de Janeiro, Minas Gerais, but maybe in other places we won't be able to do it so easily. So, like in the Midwestern center of Brazil, in which the population scattered around the states, and the ability to train in human health emergencies. It's hard to find professionals that have leadership roles and profiles and the ability to be able to educate onto work processes and the team as well. So this is quite important. And I've been stressing here within the Ministry of Health, the workforce of SUS, they often action or carry out these management activities in terms of the environment to be able to increase the efficiency of the response. And from these factors that we identified, the Ministry of Health has established an action plan and a strategy so that we are able to deal with all these fundamental factors and also to have a structure for agile response when dealing with any health situations and emergencies, be them national or localized at state level or city level. And now we're moving on to in October 18th, by the current minister, Marcelo Queiroga, this action, the strategic action. Its goal is to strengthen the ability to respond quickly for SUS in health emergencies. So the action is comprised of 5 axes. It stems from updating the platform. So this is the first axis, updating health workers in the platform. Like I told you before, it's for registration and training for health workers. So we need to know where these professions are at and what are their abilities, their skills, and what kind of training have undergone already, and to get to know better this profile. Like Dr. Malicho said, it's not enough to know where they are, but also to know what the skills are and what kind of situations they're used to dealing with. We have also prepared for the second axis, training focus on the approach of critical patients. So we're going to go through it quickly. It's like an attack phase in which I'm going to explain it better further, but what we intend to do here is to train health workers and throughout the entire territory of Brazil so that we have this mapping of health workers with determined skills and abilities. And then support to training centers and structure. So we have a steady structure for training and in an agile way. So we know where these training centers are and we're able to train health workers regardless of where they are. So we don't have to move professionals from one region to the other to carry out the training, and updating protocols for basic support of health support from the Ministry of Health, just like the Heart Association protocols and the American College of Surgeons. Some of those also have life support protocols. There are relatively out of date. The last update was on 2017. So it requires an update with the lessons learned throughout the pandemic and to be able to cope with this management issue, training and dealing with health emergencies. The first axis with updating the platform has as a goal to create a database with information on health workers that are qualified and available to act in health emergencies. And why they are qualified and available? Because when we're talking about that in Brazil, we have a lot of professionals that self-declared available to act in health emergencies or dealing with the pandemic, to be more specific. But when we got to the place and we tried to reach them, they were not necessarily available or willing to move from their state to another region. So all this information and details and where they're willing to go, this is quite important to be able to place and allocate the situation, these workers. But we need to have a better notion of how the scenario is working and the health workers that we have to cover a specific place regardless of the reason for this vacancy. So we need to understand where we're getting these professionals from and move them to where they're needed. So the target audience would be health workers, managers from SUS that are going to make use of this database to be able to hire professionals either temporarily or in the definitive way, or professionals that are working outside of SUS, and the National Task Force from SUS. And this team works with health emergencies and public health emergencies and voluntary health workers. And they don't have a database that is well structured. They do have information, they do have data regarding voluntary health workers, but we are striving to have a more structured database. And the expected outcomes, we have the register on BRCC, which should be up to date, and we are able to organize the task force from SUS that will be a key element to respond to the pandemic. Now, on the axis for training, focus on the approach for critical patients, what we want to do is already know health workers and train health workers, know where they are, so that we are able to give the support to SUS task force, and also to ensure that whenever we're carrying out a training, we know where these professions are at, what their skills are. So our goal here would to be provide training for skill certification with national and international recognition. And the targeted audience is health workers that are acting with health emergencies and acting with these emergencies. It's related to the expected outcomes. We expect to train 10,000 health workers throughout the entire territory of Brazil. And when we're talking about our country, we're talking about health workers working with emergencies. We're also talking about 600,000 health workers throughout our territory. So within SUS, we have 600,000 health workers. So it's to train these workers who are dealing with this approach on a daily basis, we're strengthening this response from SUS to this kind of situation. And now training will be basic life support, advanced life support for heart issues, for pediatric services. There are international acknowledged as ATLS, ACLS, support pre-hospital for trauma patients, and advanced support for trauma patients, THLS and ATLS, and mechanic ventilation and advanced airways support, which is a demand that arises with the pandemic. As partners, we have UNASUS, which is an universal system in Brazil, and are supporting us with tender processes and splitting the classes. And we're also supporting us with a technical support coming from the Ministry of Health. They're supporting us with hiring to provide this training. Now, on the structure of training centers, which is the third axis, the goal is to provide training centers which are permanent throughout the entire country, and to train and certificate health workers. While we're in the attempt of training health workers to tackle the pandemic, we struggled a lot to articulate with training centers and also to find training centers that had the necessary equipment, up-to-date equipment, and training center, simulation training center that were able to capacitate a great volume of health workers in a way that is not exhaustive or tiresome. So we want to carry out it in the entire territory, and we're thinking it should go from 45 up to 50,000 training centers in our territory. And we believe that with this number, we would be able to train in a 2-year period the entire network of health emergencies within Brazil. And as to the professionals that make up this network, we're not thinking only about health workers, but also health professionals in general, So we're talking about ambulance drivers and other health workers that are also part of this network. And it's important that they have the skill, the basic skills to support these health emergencies. The target audience of this training would be the emergency health centers. As Dr. Maria said, this center should be an integration point between hospitals and training centers that we might have at some university, and they can give us support to train this network of health workers, both in the sense of articulating them between the sectors. So beyond the health sector to the education sector and also the public management sector, but also that within the educational centers, we have these professionals who are working with health emergencies. So it's important that we have professionals that are used to dealing with this in a daily basis, with these emergencies, so that they can bring to reality carrying out this training. And for the expected outcomes, we have the autonomy of SUS for training. And when we're talking about autonomy, we're referring to that. Once this has been structured, SUS would be able to articulate in a much quicker way. And once they establish this articulation, and with other partners or having to look for other training places, we wouldn't be stuck with other companies hiring our professionals, regardless of we are facing a health emergency or not. So these training centers, beyond the COVID situations, we also thinking about other emergencies. So it's very particular to each region, to what the pandemic is being like, what kind of disasters they're going through there.
Protocol of advanced support is the idea is creating a model of competence for the Ministry of Health based on these protocols. And the target audience would be the emergency and certain centers that will certify these competencies, and we hope to update the protocols, national intervention protocols, and create a method to ensure the accreditation method to ensure an interesting level of the quality of the training of those professionals. We don't want just to train them, we want to ensure the quality of this capacity building and ensure that the professionals have their skills updated and that they're used to deliver these maneuvers and procedures. So we are having better effectiveness in the assistance and healthcare, and we create the recertification of the Ministry of Health so we can know where the professionals are, if they took our capacity building or not, and what we consider with a quality, a minimum quality to be able to act in a satisfactory way is to know where they are, how many they are, what is the possibility of mobilization, and the last factor that we want to approach would be the training in emergency situations. And then this objective would be to qualify the health professional for the planning in health situations. And then we're talking about work plans within a intensive care unit, and we're talking about a setup of a team with the firefighters, police, and society and the community that could be also available to help in this kind of emergencies. A professional with this kind of profile that could understand and extract the best of, so we can extract the best of each professional from each category to have a more fluid workflow. And the target audience would be health professionals, state managers and local managers, and also the managers of the health units themselves. The idea with these capacity building would be to strengthen the skills and the capability of the healthcare system at a local, national level as well, and to give an integration among the different sectors, local sector and emergency situations of public health. So we can also be involved in the educational. So the courses that we are designing in this first moment, they are already being validated and management of emergency situations in public health and the management of intensive care units that are the emergency network would be where we have more pressure would be the ICU and the health emergencies services, and we need to qualify and train the management of these units, which would mean a very important step towards having a better emergency or crisis situation management. Considering the different specializations, we have been thinking about different level of actions and a technical level that would be for all health professionals. Of course, these trainings will be composed by independent and complementary modules. And the technical level, the idea is that it should have a general model for everybody that takes Brazil Conta Comigo participate, but also technical level requirements. And that, for example, an ambulance driver and a nursing technician, what would be the role of each professional in this action at a higher educational level as well. Well, according to the higher education level, physiotherapists, pharmacists, everybody would be considered in there, and a training drill or simulations, realistic simulations or trainings that would be as the National Force of SUS promoted now, realistic simulation with multiple victims. And the idea is that these professionals from time to time could perform those trainings, and they can themselves put into practice what they have learned with the theory, and it's part of the learning, right? To carry out what we could learn and have more familiarity with, and to be placing ourselves in these situations. The idea would also be to be offering certificates for these kinds of capacity building and trainings, and obviously we're going to open specializations for those professionals that already have performed or taken the higher education technical trainings, and then we're talking about lactose specification with a certificate, 360 hours, so these professionals could have in their curriculum this graduation of experts in emergency crisis management, and we could then evolve in terms of the qualification of our workforce. I believe that's it. Maybe I was a little bit too quick. I don't know if you have any doubts, questions. I apologize for, at first, I was talking to Professor Maria Helena. As I said at the beginning, we are going through a transition moment in our management. And besides that, we're also going through a matter of, well, some losses of professionals in our team that are absent due to COVID-19, and I need to participate around 11 o'clock in another appointment and agenda, but feel free to make questions, comments. I will be available to answer them tomorrow, because tomorrow I will also be here participating, and I will have more information on what was the strategy, Brazil Conta Comigo, Brazil Conta with me, and what are the results and outcomes, and if you have questions, I can answer them tomorrow. Thank you so much. I hope I had a presentation as good as Mali Cho's presentation, so I wish everyone a good day. Thank you very much, Marcelo, for showing us the strategies used by the Ministry of Health for tackling different public emergency situations in Brazil. Certainly your presentation brought us crucial aspects and extremely relevant strategies used so Brazil could have trained and skillful professionals and more agile answers and responses and sustainable for these different situations. Thank you so much for your presence here and for sharing with us so important data. So here we can continue, and we'd like to invite Professor Adriano Massuda, who is a sanitary doctor and the professor of the Foundation Getúlio Vargas, and also a researcher at FGV Health. He graduated in FPR, he is resident in preventive medicine and doctor in collective medicine at Unicap University. Had substitute at the Municipal Secretariat in Curitiba, Secretary of Science, Technology, and Strategic Inputs on Material for the Ministry of Health. Internationally, he was a visiting researcher in the Department of Health, Global Health, and Populations, Harvard TH, and also the consultant of WAHO, and part of advisor panel on value-based healthcare, and also financial field innovation of medicine. And he was also a commissioner of Lancet Global Health Commission on financing primary healthcare. His research lines includes the management of health policies and health systems and innovations as well. Thank you so for your participation here, Adriano. He will be speaking about the topic, key points for for health and managing the pandemics in COVID-19. The word is yours. Thank you. Good morning, all of you. Thank you for the invitation, Professor Carla, Professor Maria Helena. It is a great pleasure to be here participating in this international webinar, focusing on the discussion of human resources and health emergencies or health crises, and we're going through the main ones at least in the previous 100 years. At least it's going to leave to us lots of lessons learned, and I believe in such a seminar is fundamental to debate and discuss mistakes and successes, so we can try to strengthen our health system to tackle these emergencies. I had an experience in the Ministry of Health when I was a joint executive secretary. I coordinated my crisis management office in the ministry, and this emergency that we're experiencing, these pandemics now, and also the emergencies in Petrópolis. It was due to the situation that we created back then with Minister Alexandre Padilha. We created the National SUS Task Force, and as Marcelo was saying, this task force is very important, and it could be better used in response to the pandemics. But well, I will make a presentation on after Adriano has this experience of SUS and the ministry that I had experience to study with an international research group that I have collaboration with that studies only these healthcare topics, and I came back to Brazil very well dedicated to study SUS, the Brazilian Unified Health System. And this pandemic is an opportunity to understand better these fragilities, but also the strengths. I will try to show a little bit of the road of the studies that we have been developing in collaboration, that I've been taking part in. Some of these articles that have already been published, and some are still in phase of publication, but trying to look a bit towards the topic and the key points of the response to the pandemics. I'm going to share my screen. Let just me know if it is okay. Can you see the whole screen, the full screen? It's not on full screen mode yet. Okay, let me see. Zoom sometimes does that with me. Okay, now it's better, right? Yes, much better now, Professor. Thank you. So the key points for SUS response to the pandemics, that's the main topic of the speech. And the lecture, and we're talking about this since 2020, so we have about 2 years of experience in this presentation, right at the beginning of the pandemics. we gathered a group of researchers that already had experience with SUS and economies to make preliminary studies about the estimation of costs and resources that we would need to give support to the response to the pandemic. And it's important to say this: we come from a context of a health system which is underfunded, and also in this economic and political crisis, fiscal authority, this SUS was even worse. And in this context, we would need then the resources to subsidize the expansion of hospitalization and admissions that would happen. That's the first technical note that we launched together with the Institute for IEPS Institute in March 2020. And then resources to cover the admissions and the needs of infrastructure, investments to have more hospital beds, intensive care units, and respiration, artificial respiration machines. And we also would have done the analysis of how the scenarios would be in the pandemics, considering the distribution of hospital beds that we had in SUS. And in this context of 2020, April 2020, we published then, considering the analysis that we were making, international analysis as well, and our own experience in SUS management, the Brazilian health system. So we launched this technical note in partnership of FGG Health and IEPS that coordinated with Professor Marie and Gustavo, Miguel, Tasser, and we tried to list the key points for the management of SUS response to the pandemics. That is the main topic of our presentation. And here we could establish 10 main points. The first would be to establish a governance structure and coordination to respond to the crisis, activate a crisis management office that would work in an articulated way with the different instances of SUS. It's important to have a general overview of the system and a structure of governance that would give this response to the planning and set of actions considering the phases that the countries would face. The first cases being recorded, the increase in the cases, the exponential increase of cases as we were already seeing happen, and we published that in April. We were already seeing the different experiences, the horrible tragedies in north of Italy and the USA, and we saw this increase of cases. So we needed to have a strategy for these to mitigate the impact, and also instead of action having made in the territory vulnerable groups with the greater vulnerability, mapping the installed capability of those areas of greater needs to give us support to this response. This program for the implementation of a proposal needs some funding, and this funding should be an extraordinary resource. As I said, SUS is underfunded, so this funding was very important to have extraordinary fund to it, so we could have an emergential fund to cover the costs of this response. And it's a specific action that's there we focus on health professionals and reinforce the training so we could have the better services with COVID patients with protection and safety. The trained workers, but they would also need the PPEs. Considering that we were in a context of difficult access to those PPEs. And what will they be? What PPEs are they? Well, we will need to ensure that the supply of products for the hygiene and the cleaning and PPEs and supports of life. And this would be the base of the management actions for information and communications of the risk to understand in real time the spreading of COVID per location and per region, to establish then the response actions and to establish a routine of communicating the epidemiological measures and information for the disease and actions to restrain to control the transmission and the reinforcement of social distancing and cleaning, hand cleaning, and the use of masks. That was very important information for that time, and that needed to be implemented, and to start this survey or this research at the regional and national level to encourage the prevalence of the pandemics through rapid testing at that time. That was what we were suggesting. The point of view of coordination of the existential network and a set of strategies to organize the line of care for COVID patients, establishing flows for those patients supported by the primary healthcare, emergency hospital emergencies, and isolated patients that did not need to be admitted in the hospitals. And we discussed the health support that we needed to give to this pandemic. On the other hand, a parallel action of reinforcing the assistential regulation and the monitoring of the occupation of hospital beds in public hospitals, but also in the private hospitals, having that due to the need that we would need to of rapid hospital bed expansion. And we also discussed the need to have a preparation of the municipalities and the states in the point of view of registration and registry and managing the corpses and the bodies due to the high increase of deaths as we saw. The measures of mitigation of the social and psychological and economical impacts due to the pandemic's impact. Well, that is what we published then in April 2020. And from that point on, we started using that as a base to carry out studies. We were contemplated in CNPQ's public tender to tackle the COVID-19 pandemic, and we developed a very broad study which is still ongoing, and I'm going to show some outcomes that we could see on how the general question was, how was the response of the Brazilian health system care system to COVID-19. The general objective would be to analyze the general actions at municipal, local, municipal, state, and national levels, and identify how were the national response and how we organized ourselves at state and local levels, and to highlight the innovative experiences that states and municipalities that had positive results controlling the pandemics. So this is a study that, well, we have a study platform that would have the international analysis, comparative analysis through the hydrographic analysis, but also interviews with the key stakeholders in different countries, Italy, Spain, Australia, Peru, wherever we had our associate researchers. One of that was Renato Tachi that worked at PAHO. So we had a very good, very large contact network. And national analysis of SUS, a more general analysis, and to be able to consider these local experiences, we had some case studies, and we worked with different databases, and we use the quantified methods. And I'm going to show you very quickly here some of these results, because it's a lot of stuff. Well, first, as an international response, we used as a base the health system response monitor from the European Observatory of Policies and Health Systems that works in partnership with the European Union and the World and WHO. And you could be comparing the comparisons of the countries based on the different actions. And from this international analysis, we also made a publication of some articles. We could compare how the countries would be using the private hospital beds for supporting the response of the public health systems. That was a very important issue at that time, when we were seeing the need of rapid hospital bed expansion, and the use of the private hospital beds could be an important resource, but it was not used at a national level.
There were some local experiences from cities and states that established rules for using private rights, but this was not a national rule. So we established a national strategy for responding to the pandemic. In Italy, right at the start of the year. So we sought to analyze the resilience of the health system responding to the pandemic. So we have an universal SUS, which is decentralized, and this establishes a quite diversified network, which is a fortress for responding to health emergencies such as COVID. And at the same time, we have some weaknesses and challenges. So we would try to describe here in this paper aspects regarding to the leadership of the system. So frailty and strength but also financing the system, outcomes and strategies, our workforce, information regarding health, and also from the perspective of providing services for health emergencies. In each city, we have a health team which is trained. So this would be fundamental to have a quick response, uh, such as COVID. Unfortunately, there was a lack of management. So we are going to demonstrate that throughout the study. Each city has responded differently. So in an isolated manner, so it was not articulated with one another. And the key attention here, which is fundamental as well, but there was a lack of guidelines and preparation for that. So there was a lack of preparation at the start of the pandemic to prepare community agents to respond to the pandemic. So we have 450,000 health workers, which is fundamental to identify a risk situation, a population in risk, to support this population. Public health services in Fortaleza and University Hospital in all the states, but this is one of the areas that is more frail. And it was demonstrated in this study that over 70% of health units hadn't got enough beds for regular situations. So these were quite vulnerable regions for any emergent situation in which you have a lot of cases. So they could collapse due to the pandemic. So unfortunately, a lot of those were not able to cope with the pandemic. So there is a network of ambulances, SAMU, who deal with these health emergencies, but they're also fragile in this sense. And virtual health systems would be this strategy. A lot of cities have implemented that. The private sector in Brazil has also made use of this as a leverage for the pandemic to progress in the use of telemedicine and medicine on the phone, and to have online services either to monitor the cases. We use these experiences, but once more, there was a lack of coordination at a national level so that this could be used in a more effective way. So what we demonstrate in this paper is we try to analyze the resiliences of our health system, our response ability, and the challenges as well. So this is a paper about on the analysis of Brazil's response to the pandemic. So this paper was really good to deal with this issue, and it was prepared by professors from FGV and Harvard University, in which we described the trajectory of the pandemic. This paper was published in April 2021, and we collected data until October 2020. So this is at the start of the pandemic, and the second year was even worse. But we demonstrated that social inequalities that existed apart from age and the status of health and other health factors for COVID, as happened in other countries before, because the pandemic affected more regions that were in which there were more elderly. But in the case of Brazil, the regions that were more affected were those who were more vulnerable in socioeconomic terms. So he has established the trajectory of the pandemic. So different from other countries, we promoted a load which is not proportional between states and cities with a high vulnerability. On the other hand, we demonstrate that responses from local governments and the behavior of these populations, even in states and cities that are the most vulnerable, have helped us to prevent the effects of the pandemic. So it's necessary to have policies to reinforce these actions to the places that are most vulnerable. This is another paper which was approved for publication yesterday, and it's gonna be published in Lancet America. And the previous paper, we studied the effects of the pandemic and the impacts of the pandemic on the death rate in our country. In this paper, we sought to study the resilience of the health system stemming from the impact of the health system during the pandemic. And for that, we analyzed the production of the health system in terms of different actions, different procedures, diagnosis, screening, transplants, surgeries, medical appointments. And what we have demonstrated so far in this paper is that when you compare 2020 to 2019, there was a reduction of 25% of the average SUS production in comparison to the previous year, but in a very diversified way in terms of certain procedures. So procedure of diagnostic was the most affected ones. Surgeries were also very affected. And some states, just like the previous study, the most vulnerable states were the ones that had a larger reduction of this production. So we had a larger impact on SUS production. So, and this led to consequences, future consequences. So in the short, medium, and long term, so the direct consequences in the delay of carrying out these procedures for those who have clinical conditions like oncology, heart surgeries, they're gonna have consequences, a drop in carrying out the procedures regarding cancer, monitoring and vaccines. This dropped a lot as well. So this delayed the diagnosis, and we have received reports in terms of this late diagnosis in terminal cancers, for instance. So there is a sum of this demand that is going to pressure the health system. And now moving on to the closer to the ending of the presentation, we also work with study cases, and we have done an intentional selection of 3 cities to analyze in depth. Our goal was to represent our national reality, but which we selected due to relevant experiences. So we selected some cities as a sample that Peiho has carried out some experiences throughout the pandemic. So we carry out interviews at different times for testing the pandemic response with managers from the cities. And the key questions followed the script, seeking to analyze the key elements of SUS response to the pandemic. So how they implemented this in different cities. So the municipalities that we analyzed was Fortaleza. And as I said before, the responses were very different. There are common points, but it was very diversified in terms of types of response, like in Fortaleza, in terms of management coordination, but there was a complete articulation with the city and the state of Ceará. And this helped so much with the planning, but also with the coordination of the crisis committee and communicating to the public, but also management inputs, which was a challenge because this was one of the regions that was affected right at the beginning of the pandemic in April. So we had a very large impact and a lot of cases. Pelotas in Rio Grande do Sul was also an affected city, but it was affected at the end of the year. So at the beginning, it was quite smooth, but then at the end of the year, it became severe. And what stand out in Pelotas was also this articulation with state of Rio Grande do Sul, but they developed this partnership with the Federal University of Pelotas, which helped us with carrying out exams and plan the response to the pandemic, a larger actuation and network expansion. And what stands out in Uberlândia was a presence of social organizations when managing services for the cities. And this, on the one hand, has allowed them to expand better, and the networks are more agile, but they also struggled in terms of the Secretariat of Management with social organizations. I'm not going to go into much detail so I don't take too much time, but what we did so far in terms of prevention actions and surveillance actions as well, in terms of mobility restrictions, what kind of strategies we use, monitoring strategies. So to test it was quite hard. Isolation measures were also a challenge. And last but not least, support to health systems. Overall, our attention was focused on that, but it was done in a very diversified way. It was very different from what we expected in the response to this pandemic. In Fortaleza, for instance, the role of this assistance began quite weak, but got stronger over time. And as it got stronger, it proved to be quite effective when dealing with the pandemic. So this was described in the manager's reports, but also analyzed in the data analysis. And hospital actions were a general challenge for all. And what stood out was this drop in the low participation in the private sector to the response of the pandemic. So SUS in some cities, SUS was more resilient than the private sector, and the complementary health sector, they were overloaded first. So SUS got this spare load. So they got the patients from the spare health system. So this is a summary of what we have been talking about, and these outcomes that I'm showing now, they are going to be published in this paper, which has been already approved and is going to be launched in this magazine to describe what has in common in terms of tackling the pandemic. And we're describing in cycle, in a reactive cycle, due to the lack of planning, of a previous planning and a previous coordination at a national level that provided guidelines in terms of what could be done. So the cities, a lot of times, were isolated, and then it led to this response coming from a lack of preparation, and also on a challenge, but at the same time, as we implemented the first actions, people starting to feel proud of their responses and also to acknowledge the importance of SUS by population, the importance of health workers. So this motivated managers to implement creative measures and innovative measures as well. But as the pandemic was so long and it killed so many people, including health workers, a lot of health workers actually, leading them to exhaustion and fatigue and to a crisis situation. So the response at sometimes were quite effective due to the resilience of the system, but as the pandemic endured so long, it led to the protagonists to be tired and exhausted and continually tackling this pandemic with a huge challenge. So to wrap it up, we're going to see Brazil's response to the pandemic. There are many doubts, but some certainties as well. We know there was a lack of planning, a complete lack from the Ministry of Health in the coordination of the response. And I can say that because I worked there. So we coordinated response to the Zika pandemic, and they have an important role in coordinating the response. So the federal government struggled with responding to the pandemic with irresponsible actions coming from the President of the Republic in questioning measures that are definitely effective towards the pandemic. On the other hand, this made room for state government to act. So this led to a structural change and also to a political change. So it's important that state government has a bigger role in this response now, and I hope this becomes a legacy of the pandemic. A lack of prepare led us to a reactive cycle like we described before in the previous slide, but also we were possible to observe a very proactive cycle. The way that we are delaying the procedures and we gather around 1,000 people per day, we're not able to control it fully, but we can see the impact of this delay taking place. And one of the debates that we need to carry out is that SUS many times have demonstrated to be resilient and to be complementary to health system, but it consumes 96% of our health resources. So the private sector should have larger contributions to this response because they have enough resources to do that. So our research teams, Professor Laura, Ana Maria Malika, Renato Tasca, Mariana, Dante, Alessandro Bigoni, and also students from FGV University who were a part of this research. And these were inevitable. The crisis is inevitable, the response is not. We thank you so much, Dr. Adriano, for your excellent presentation today. We thank you so much for sharing us evidence, scientific evidences, approach addressing fundamental keys, pandemics, and crucial factors to us management structure and efficient coordination structure to different crises such as the pandemic. Your speech has brought very relevant data and also give us food for thought for our next debate on this theme. Thank you so much. And now I'm going to give the floor of Professor Marcelo Norique Zufo. Professor Marcelo is an electrical engineer. He's a master in electrical engineer. He also has a PhD in electrical engineer, and he's a tenured professor in electrical means and mediums. He's a tenured professor with the Department of Electrical Engineers Systems in the Universidade Politécnica de São Paulo. He has acted with the Laboratory of Integrated Systems, coordinating researches and development in the area of interactive electronic means, focused on the following themes: interactive electric systems, high performance computing system, digital reality, graphic computing, and in 2001, he developed his first system of digital reality, which of immersion in Brazil, which is called Caverna Digital. He's a coordinator of Audit and Research Center of Brazil, and since 2011, it's been coordinated the interdisciplinary system of interactive technologies from USP. Professor Marcelo is going to address USP's project and tackling the pandemic of COVID-19. Thank you so much, Professor. The floor is yours.
Good morning, everyone. I hope you can hear me just well. Thank you so much, Professor Carla, Professor Helena, and our friends from the School of Pharmacy in USP Ribeirão Preto, our friends from WHO, FGV. Well, we're here from the Polytechnic School, from the Engineering School. And we are mobilized since March 19th, 2020, when officially it was decreed pandemics here in São Paulo, and we were forced to evacuate the University of São Paulo due to the lockdown. And in this turbulent moment, we had a process in the Polytechnic School of convergency of several professors in different expertises, specialities. I myself, I am professor in electronic area, and I have an experience in the health aspect due to several. Well, I worked in the Pediatrics Ecological Association. We were pioneers in the consolidation of telemedicine networks in Brazil, and the 80s and 90s still. And the pandemics came with a great tsunami to us, catching us in a surprise in this situation where we had lots of questions and doubts, and if we would really have the conditions to support this wave, considering the infrastructure of health that we have available in Brazil, mainly SUS, the Unified Health System. Brazil, in the biomedics point of view, is very well served in schools of excellence. It has a relatively strong industry. Brazil is a country that exports ventilators, but we didn't know if we would have enough hospital beds, because the secondary problem of COVID-19 would be the acute SARS. It would be the demand for ICU class equipment. and we didn't know if we would have available ventilators. And I would like to share some slides here. And I hope you can see my slides right now. Everything's okay, Professor? Yes, it is. Excellent, Professor. Well, we are an agile engineering center, and we surprisingly have a plant in the University of São Paulo. So everything that you see now is made in Brazil. All the inputs, all the material of INSPIRE project were projected and developed in Brazil. Therefore, differently from other sectors of the economical activity, we didn't have any problem. And supply chain network for fabricating these ventilators. So we worked strongly in these processes, creating the name of this project, Inspire, because we also would like to illuminate and motivate, encourage other engineering schools in Brazil to have this movement to fight against this virus, which is a health problem that can not only be tackled by the health perspective, but also with a great mobilization of the whole society and the programs associated to it that previous colleagues have already mentioned. And we work in an open innovation process. So on the right, you will see the first prototype of this ventilator, artificial breathing machine, in 3 weeks after March 19th, and to the right, the product. To the left, the product. From the development to the massive distribution of these ventilators, we could perform this process in 120 days with the due certifications of the Brazilian health authorities. In the case, Anvisa, and the surveillance agency from the state of São Paulo. So in our case, the project INSPIRE, it's a full Brazilian domain over all processes since the conception to the product development, articulating interdisciplinary networks. We work with the process open innovation ecosystem, and we have the ventilator project, and we dealt with the supply chain issues, and we also used a terminology which NASA uses to define the maturity of its products, which is TRL1, we call an idea. TRL9, we call product in the shelf of the supermarket. In the case of the ventilator, the product tubing the patient. And we did that in 3 months. And we have now 1,000 operational ventilators in 17 states of this federation. To update these numbers. I will update these numbers better for you. And the situation in March 2020 was desperate. We had reports of doctors and nurses committing suicide. The famous case, the nurse that jumped from the building in New York. There were cases reported in several countries. In Europe, with more emphasis in Italy, and everything was restricted to a fundamental issue that was the lack of ventilators. And therefore, a level of stress of the healthcare systems at a maximum level that some colleagues took these sad decisions. And the needs. Well, the need is lung ventilators. And lung ventilator is not a mask, it's not a pillow, it's ICU class 3 equipment, normally with engineering criteria that I would say very close to an airplane project. So it is not easy from the engineering point of view to develop a ventilator. Normally, before we developed that, we were saying that in Spirit, we talked about 5 years for the conception, development, and homologation approval of the ventilator. The problem is that what we are using engineering expressions here, right? Needs, problems, technical requirements. What we needed to make a low-cost ventilator, and then we would have a break in the paradigm Ventilators normally were expensive, few, hard to maintain, hard to purchase, and fruit of the whole problems of lack of ventilators in the COVID-19 crisis. So in our case, we put low cost ventilators requirement. So we were talking about 20 times cheaper ventilators compared to the commercial ventilators in the same category. Ventilator to be used in a contingency scenario, and that means that the contingency, well, we didn't know where the ventilators would be used. It could be in a hospital bed, in ICU, or in an ambulance transporting patients from one city to another city, called Nova Goiânia, or in an airplane, or in a fire's vehicle, or on the way to the hospital. And we assessed all these situations for a Inspirity project. And at first, I would like to thank Brazilian Navy, the Air Force, and the Brazilian Army, and the Civil Defense, and the military and civil police from several states of our country, and also the Civil Defense, and lots of volunteers that helped us to set up this humanitarian logistic network. And at the same time, we had what we called war economy, pandemic economy, and the supply chain were broken due to the public policy protocols. For example, we could not transport equipment to European countries because European countries activated during the pandemics war economy procedures, and if we transported material to produce ventilators to the European countries, I will not mention the countries here, the equipment would be seized. They would be arrested, seized due to war issues. And we had that reported in the press, Brazilian cargoes that were held in European countries and also the USA. And besides that, you probably saw that we had other problems, political problems like corruption. We had 2 operations of the federal police. And in this whole mess, the Inspirity project was born. Premises of the project: absence of compressed air and oxygen, low cost, compact, robust, biosafe, manufactured in less than 2 hours, components for easy of assembly, fully compliant to Anvisa requirements, with clinical validation respecting all of the protocols from the Ministry of Health, CONEP, and Anvisa. Validated clinically, discardable. We believe that the pandemics would end and these ventilators would be returned. But for our great surprise, they were not returned. And lots of hospitals in Brazil that never had seen or heard about a ventilator in life, they are now using it to treat not only COVID, but also influenza and other diseases originating from the SARS diseases. Well, conditions of 24/7, 24 hours a day, 15 days, and open radio software system. To the right, you will see the first version 1.8 of the ventilator. And continuing, we use then the technology of support to ventilation, which is the most universalized, AMBU. For those of you that do not know, for the manual resuscitator is represent a perfect representation of the lung. For us engineers, we know all of the equations of AMBU. But Professor Raul Lima, who is our colleague, is a post-graduation course at USP, explaining the mathematical modeling of this product. Well, that's everything we needed from the engineering point of view. If we were able, using these mathematical equations, to generate a process where we would simulate very accurately the algorithms that the lung therapy protocol learns at university, or nursing, medicine course, or any specializations in health, well, we're done. We would have a ventilator there available. This approach then would have kind of prejudice, but it's something very silly. At the University of São Paulo, we do things based in science, and we can prove scientifically that the approach is extremely correct and proper for it. Well, 3 weeks later, we already had our prototype, AMBU pillar, controlled by a very accurate motor, a high definition screen with telemedicine resources. Our ventilator, yes, it's probably the only one in the world possible to export real-time data for anywhere in the world as well, and compact equipment that fits in a case and you can carry it around. Well, that is in practice. In theory, and the engineering behind that, the process is very complex, and we used very rigorous methods of project engineering, and we have one version here of the block diagram for this ventilator. And from that point, we started projecting the electronic side, and it's a very compact electronic, and we have the electronic technology at the University of São Paulo called Caninos Locos computing platform. So as soon as we made that ventilator, the same week, everything became algorithms. In the end, all of the procedures, VCV, PCV, and assisted PCV, now we implemented several methods. They are algorithms. And we have know how to implement these algorithms. Well, that's the project's timeline and concept. It starts in March 2020. We already had the prototypes, first prototypes 1 month later, April 2020, and we started immediately with the veterinary medicine University of the São Paulo campus performing tests in animals, and we generated version 1A. We learned some things performing these tests with animals, and we generated version 1B, and we submitted to Anvisa in September 2020. We had the ventilator approved. And it seems, well, here we could see the Polytechnical School working with a Brazilian Navy battalion, 80 Navy officers as volunteers. They said, well, we are here ready to help you produce the ventilators. And then together, from September 2020 to November 2021, we joined this adventure to produce and distribute ventilators throughout Brazil. Here we have the maturity scale of the project, as we call, from TR1 to TRL9. We show here the phases. April 13th, we made animal tests. July 16th, we had 50 ventilators with human tests approved by CONEP and Anvisa, and we, in August, could get the Anvisa approval. And the ventilator. Okay, here we have the technical specs. It's a ventilator to work with a car battery, because we have, or an automotive battery. We send these ventilators sometimes to Parintins in the Amazon. We send these ventilators to Amazon tribes in Xingu area, and they could be used also in ambulances, transporting the passengers, the patients and passengers, used by the civil defense, the civil police, and the local city halls. It has a touch screen, 7-inch on and off switch, digital, and the oxygen entries. It's good for hospital beds and also emergency transportation ventilators. Here you could see the ventilator connected to the artificial AMU, and this is our consentment to Anvisa. Exceptional consentment for the manufacturing, commercialization, and donation of equipment for respiratory support, automated type. So this certification has some kind of prejudice that is absolutely overcome, because now we have 1,000 ventilators in operation already. And we could also say that Brazil was the only country in the world to get to this level of maturity, technological maturity, with this kind of technology. Well, this is the current version of the ventilator, version C. We use several 4.0 manufacturing techniques. Yes, it is a 3D printed ventilator, printed in a 3D machine. So we would like to thank several companies like Votorantim, Ambev, beverages donate to us all the plastic, and the electronic was projected by the Polytechnical School. All the electronic side of this ventilator is reduced to this board, produced here in São Paulo, and this board is produced in Sorocaba city and mounted in the Polytechnical School. You will see some places here that are very weird. Well, yeah, Brazil has an industry of electronics. Brazil doesn't depend only on China and USA to do this stuff. We did everything here, and this is one of the models for which the product is so cheap. That's one of the reasons. Well, when the first wave concluded, they said, well, let's stop producing ventilators. We said, no. We went to the engineer. We are engineers. We understand about mathematical functions. We interpret equations differently from other people. And we knew that we would have the second wave and probably a third wave. And we knew that the second wave would be even worse than the first. And that's what happened. And all of our process, this orange line here, is our production, accumulated production process. And we're very proud because who in Brazil called to us and ordered ventilators receives the ventilators. We did not leave anyone behind in Brazil during all this period. And I'm going to show you these graphs here. So we are able to get this visa approval right in the drop of this first wave, and you see that the projection for the second wave matched perfectly with the production of the ventilators. And you could see that the problems of lack of ventilators or absence of ventilators disappeared in the price, even though because our ventilators is very cheap, it doesn't have the cost of the property, as we call. So we sent the ventilators to Ribeirão Preto, and we had a peak in the demand in Ribeirão Preto. We only needed to get from São José to Rio Preto and take it to Ribeirão Preto. The military escorted, and the ventilators went there. After they used it, they returned it to us, and we sent it to other hospitals. Well, the ventilator has several innovative technologies. It is made in Brazil. It has 4.0 technology. It has Internet of Things, IoT, but most recently we are adding artificial intelligence to it. And I'm going to spend my last 5 minutes talking about other things of Inspire, Inspire project. So I'm going to share some internal information. We used a lot the lung simulators. So basically, we don't need to use human patients to test the new protocols. We have a full lab for approving these ventilators with certified equipment by the North American FDA. And we have a lung ventilator certifications infrastructure. This is one of the phases of ventilator testing in the Polytechnic School. Any procedure published in the literature in matters of hours, we can reproduce, apply in the ventilator, and test. These are some, we have the 3D technology in the university. For example, I need a new mask. So we have a 3D printing of the project in matters of hours. This is the ventilator C version. It's a very simple product. It is a very well professional product. We have a client service system implemented here. And this is the last version of the board, electrical board. And we put Wi-Fi, Bluetooth, 5G, GPS, and the division of the special forces of the Brazilian Navy and the American Navy want to militarize this ventilator so we can launch with parachutes in the middle of the Amazon, and we put it in ships, we can put it in cruise ships, high seas. We are already discussing all the approval and certification of that. This is our plant, and this is a historical picture. We have a picture with the kids, the professors, everybody very tired, and this was the first lot of ventilators in May 2020 still. And this is the plant that the Navy set up. Unfortunately, the plant was dismobilized, but the interesting thing is that we are able to set up the plant in containers and dispatch to any places of the world. The space we need to produce a ventilator is very small, so we have some discussions ongoing with some African countries and eventually to reproduce the process there.
Como montar uma fábrica, tudo isso daqui, tá?
We have the entire documentation of how assembling a plant, and this is referring to the second wave. So this is the distribution map for Brazil, the University of São Paulo. We use 27 ventilators. USP has distributed 854 ventilators. So these are all the Brazilian states, so that you can have an idea. Once the second wave started in Manaus, Professor Raul, who was hidden. He got a plane and brought 50 ventilators. He was not vaccinated, and we attended 14 hospitals. So we have heroines who are unknown. One of those are Dr. Natasha, who I never met before, who helped us to assemble 50 ventilators in hospitals. And our ventilator is very economic in terms of O2 spending. So we know that we have helped a lot of people in Manaus. Next steps moving forward. So I'm going to show it quickly. We have the telemedicine implemented for the ventilators. So USP ventilators, they pump all the data to a central server. And then we are able to monitor in real time from our smartphones. So in the matter of lacking specialists, the EG, the volume, the pressure, the ventilator mode, and the alarms, they can all be monitored by your cell phone. And last but not least, to wrap it up, this is the last version of the ventilator, version T, in which it's more compact and lighter and has something new. The screen is larger. We have a 10-inch screen because now this is a multi-parametric screen, which means that the ventilator is a small hub for IT. You place it in the ambulance, you turn it on, and you can have an interface between heart rates, respiration rates, all of that within a single box. So people are going to ask about the amount, the cost of the ventilator, the cost of it when packed. I'm going to show my last picture here. The ventilator, when it's packed and to operate for an entire month, you can see the box there. You can see the battery there, a car battery, which was certificated by Anvisa. It costs 5,700 reais once it has been invoiced. And with that, I would like to thank you all. Thank you for the attention. Thank the colleagues from Ribeirão Preto. This project has used 400 voluntaries, and we would like to thank the Association of Polytechnic Engineers, which are engineers who are graduated from Universidade Politécnica, and these boys and girls who are brilliant. We have now 175 donators to the project. So we have to use 1 cent of real, apart from the time of the professors from the university. So that's what I had to say. Thank you so much. I thank all the volunteers, all the donators, and everyone who was involved with that. Thank you.
Muito obrigada, professor Marcelo.
Thank you so much, Professor Marcelo, for your speech, for giving us the details on the response strategies developed by USP, by the University of Brazil, and with concrete innovations. You have brought real examples which demonstrate how much the investment in technology and cross-section collaboration has been fundamental for building the response to the pandemic. So thank you so much. Now we're going to start with a Q&A section. We have received many messages congratulating you for the excellence of your speeches, but also many questions to our speakers. But due to our time constrictions, I'm going to ask you a single question to each of the 2 speakers who are still with us. And I ask you that when you're responding to these questions, if you could please make your final considerations. We have up to 5 minutes per speaker for them to respond the questions and make their final considerations, okay? So now I'm going to give the floor. I'm going to ask the question to Dr. Malicho. Doctor, the question is the following. The database systems have proved to be a fundamental tool for this pandemic. We noticed that one of the bottlenecks was monitoring the impact on our health workers was the absence of systems to notify death cases or sickness cases. How can the World Health Organization deal or cope with this situation in the future, Dr. Cho?
Thank you very much, Dr. Carla, for the question, and thank you for asking that question. Actually, we have a notification system. This system is either to the PAHO or the WHO, and the information that we have obtained from capturing the screens, how can I say, like a special, there's a special section for COVID. And you have the information there for mortality. The thing is that mortality for healthcare workers is very sensitive for most countries because in a certain way, to show the number of people who died due to COVID, it's like a reflection of the weaknesses of the structure of the healthcare system, either because there's not enough equipment, either because they don't have proper training, or because the structure and amount of people who work there are not, they do not meet the needs. So the number of healthcare workers who died in the countries is really a reflection of these weaknesses that I mentioned. And most countries do not want to publicize that. However, the possibilities of publicizing or sending this information, they do exist. There are means to do that. If there's a close interconnection between the Ministry of Health with PAHO in their offices in the countries, this information arrive at the unit of sanitary emergencies of PAHO. We also published the amount of information about the mortality of human resources that arrive at our that are of our knowledge. And to conclude then, I'd like to take this opportunity to thank everyone. Thank you for the invitation to be here, not only because I had the opportunity of actively participating in the event, but also as a means to learn from you and from the other presentations. They were very good. They were excellent presentations that showed different perspectives, different points of view from the same problem, and still on the matter of human resources in healthcare, because this issue is intersectorial. It affects a lot more sectors than just the healthcare sector, and this interconnection should be established and it should be institutionalized, and it should norms so that you can keep all of that. Thank you very much.
We thank you, Dr. Mali Cho, for your speech and also for the collaboration. There are collaboration center. We have been a lot of time with PAHO and the World Health Organization. So thank you so much for that. And now I'm gonna move on to Professor Marcelo. So Professor, we have a question. If you could talk a little bit about the importance of this interaction, this university interaction between university and society when tackling the pandemic in Brazil, but also in promoting health for health workers when working with health emergencies. Can you talk a little bit about that? Thank you so much, Professor. I'm here with Professor Raul Lima, who would like to introduce. Welcome, Professor Raul. So Speedy has this relationship between university and society through a method, for a model of partnership. So it surprised us the volume of resources that was allotted to us in the manner of collective finances. So it was surprising. At first, we had a total of 975 donators, and then it corresponds to 40% of donated resources to the project. So I'm talking about 5 million reais. And then we started to receive resources from banks and other companies. So Banco Santander, Banco Bradesco, he corrects, Banco Itaú, Mafre, and B3, the banks. And in parallel, we had a lot of mobilization from the industries like Ambev, Embraer, Volkswagen, and each of them would donate what they could. So we had the plant here in USP, and the engineering team from Embraer and Volkswagen, they moved manufacturing managers to help us in manufacturing faster. Ambev has made available to us all the plants that manufacture plastics to manufacture plastic for us. And Tonantzin has delivered to us some tons of aluminum. Klabin has delivered us packaging. So this has showed us that the university, it can have a relationship with society in such a way that is more direct without all that formality and bureaucracy that we face usually. So this was something, it was a benefit. Regarding our colleagues, as soon as we started to implement this, we faced a secondary issue. The ventilators were too expensive, inaccessible, and very hard to deal with, to work with. So it's not easy to operate these ventilators, and each ventilator is different from the other. So we worked with two different focuses here. The remote assistance, and once more, from what we know from literature, the Speedy is the only ventilator in the world in which you can connect 3G, 4G, Wi-Fi. So we have been designing the protocols to test in clinical trials to use this technology. And we have been working a lot with the usability. So in the engineering team, we have ergonomy section or engineering of use, and we made use of researchers and professors of ergonomy to assess and make the ventilator easy to use. So you're able to operate the ventilator 30 seconds after it's been turned on the socket. So it's quick. If you have any problems with the ventilator, since we use a brake, you can turn it on manually. So you can resuscitate the patient manually. So we were concerned with that, with the lack of oxygenation or power outages in Manaus. And we have proved in the field that it worked properly and very well in these situations. So these are the two answers that I could give to these questions, okay? Because I'm an engineer, not a health worker. Thank you so much, Professor. Your speech was great. Your examples were also great. So to wrap it up, we're gonna thank you all hugely for the participation of our speakers in this panel. They gave us great speeches. And now to wrap up the event, I'm gonna give the floor to Ms. Idamara. Thank you so much, everyone. Thank you so much, Professor. We have invited Dr. Eduardo Fernando de Souza, who is going to present in a summary the National Committee of Nursery when tackling with the pandemic. Dr. Eduardo Fernando de Souza is coordinator of the National Commission of Health Emergencies of COFIN and the Manager Committee for the Pandemic of the COFIN system and regional committees. He's acted as technical assistant in República Dominicana in 2017. He was a technical consultant for the National Coordination of Health Emergencies of the Ministry of Health from 2009 to 2014. And he was also a counselor in the Nursery Council in São Paulo since 2021. Dr. Eduardo, the floor is yours. You can start. Morning, everyone. Can you hear me properly? Professor Maria Helena, Professor Aida, and all the remaining participants. First of all, I apologize to you all for being late. We're sending this team to Petrópolis, and everyone is following that on the news. So we have been very busy here in the office due to the large repercussion of this event and the number of professionals that are involved in Petrópolis and Rio de Janeiro. So on behalf of Dr. Betânia, our president, I would like to thank you for the invitation and to represent her in this activity. And I'm going to talk a little bit about what the Committee of Health Emergencies has developed to tackle with the pandemic of COVID when faced by our nursery professionals throughout the pandemic and this crisis, which remains till this day. So I'm going to start sharing my screen. Not sure if you can see it. Can you see it? Yes, we can see it. So the emergency committee, the first ordinance, the one that is on the screen, we cannot see it. No, Eduardo, we can see it. We can see it. I'm going to show it later on, our committee, but when facing the pandemic, COVID-19 in our country, on March 16th of 2020, Antonio Marianelli, our former president, he instated the Crisis Management Committee within COFEN, aiming at standardize our actions, our nursery actions when facing the pandemic. And for that, our main concern, besides constituting this committee, was to create the fundamentals and monitoring all the health institutions and all the health workers that were involved with it. So with the goal of managing this crisis and using strategies, ordinances, laws, and fiscalization process, even support to the cities, we have created this managing committee for crisis in which we have this, we gather a lot of information on health workers who were infected by the pandemic and that died due to the disease, the many demands, the lack of EPIs, all the news that people publish on the hospital, and everything that was provided by for the data protection law, even in terms of ethics, with images and situations that some could be published, some couldn't. So we found out that the best tool for dealing with that and really make an impact on the local management of those hospitals, of those services, was not simply by making a fiscalization or monitoring. It was really up to work collectively with the media. So the news that were published and media outlets, both national and international media outlets, we were published from New York Times, in Russia, in Korea, Japan, of all the jobs that we developed here was also published in Jornal Nacional. So we collected data with this tool of the response system used worldwide, but adapted to the nursing reality and also to the situation that we are facing here. So on a daily basis, we were working 12 to 17 hours a day monitoring the impact of the pandemic in Brazil. So here you can see the structure of crisis committee. It's active till this day. We were and are the only crisis office in the world who monitors and support their professionals, these health professionals. So our category, for our nursing category, started on March 16th, 2020 until this day. So the crisis committee is still active. We have a team for that, which is comprised by specialist nurses specialized in many areas, mostly emergency and trauma, but managing health crisis of public interest. So this is our crisis committee. It has the setting until this day. Our observatory, which was a very important tool in terms of data, but unfortunately, as in Brazil, there is this culture. We've faced a lot of negationism and resistance to these ideas coming from leaderships in our country. So we receive a lot of notifications about that, and our observatory has been harmed because of that. Currently and officially, we have 872 health workers who died due to COVID, and that were notified and reported by our communication teams. So all this data input and the communications regarding that of COVID cases, they are investigated and confirmed. So there are no false diagnostics or false informations. So we have large hospitals, both public and private hospitals, they prohibited that RTs would input this data on health workers that were contaminated by the disease or that died due to the disease, due to the COVID-19 pandemic. So we face this large issue because the access to it is confidential. The information is also confidential. So you need to access COFIN's website to access that. And we are already diagnosing this data in terms of infections and vaccinated professionals, but we still have a low addition rate to that, and we're still seeking this information. And the crisis cabinet office, besides creating and monitoring the situation, the quality of the assistance coming from nursing, health workers, and the quality of the environment as well, we are always concerned with that. How is the support network working in a country? Because we do know that this is already being reactive for a long time. So the lack of investment in structure and promotion. We also know that the units, they absorb this demand that was overloaded from the primary health systems. So there's a lot of movement classified in blue and green that moves from these units, and we debated the transmissibility of this workers. So that's why it was not worth to invest in ambulances, because we didn't have the structure to receive our patients. So our most important concern here as a committee was to really control, monitor, manage these resources that were available for public health systems whenever nursery was available. And nursery is available in every establishment. And as we know how the situation was back then. We studied many papers, many scientific articles coming from Fiocruz Foundation, and the reduction of the number of beds in Brazil over the last few years, and the situation that have been created by some managers that made use of this calamity and at national, international levels, and created some aberrations per se, or some very bizarre structures, but I'm not going to go into that. But we have this pre-hospital reception with ambulances, helicopters, planes, boats, which are a part of this emergency network. So this picture, and it hasn't changed. So the difference that the people are now wearing masks. And what has changed so far is the masks that the patients are using now.
And then we always had an emergency network, which was already super loaded, and we have other cities in the smaller cities of Brazil that were not ready to respond to this type of emergency. So it was even heavier, the overburden of our response system. And that will impacted even more the crisis on the emergency network. So that was a great challenge for us as a emergency crisis committee we had a full interaction with the external entities as well and the media, because we had some actions that in our competence of COFIN system in the legislation of the professional exercise, we should ensure the guarantee quality being delivered for the nursing professional to our patients. That's the main objective. But we had to also to work with nursing without touching this wound, because this wound was making our professionals become sick and become contaminated, exposing them to the virus and the unreal conditions that were demonstrated all over the media, as everyone could see. So our great advantage here was to have an opportunity to guide some municipalities to create and to set up their campaign hospitals. And humanized with good quality, everybody wearing the PPEs, following the protocols. Several campaign hospitals received good quality seals service from COFIN during the pandemic. So we had a lack of resources, and then we had another situation of the overvaluing the PPEs. And COFIN, we worked with the crisis management, focusing on the response setup in the public health emergency of national and international interest. We worked with the planning, with logistics. We bought millions of N95 masks, a great brand for a good price. And while the public services were paying $30-$40, we bought at $6 for $87, a very large amount of a well-known brand. It was very widely distributed to everyone. And we observed also the states that had more professionals impacted by COVID, and we looked for the information in our planning to set up the delivery operations of those masks, N95 masks, to our field professionals. We had to organize the internal response in the hospitals. We had to inspect the proper use of the PPEs and the systemic flows, and the health measures as well. We worked always with the MOH and the public ministry and the press, so we were very successful. Some places we were not able to reach the results we wanted or the awareness that we wanted, but we had to work on the victories we had, because we had lots of victories, and also we have a new management in COFIN-CONEM's system for the rapid response, not only to work on the guidance and support to the COVID pandemics, but also the disaster management or the emergency crisis management in the public health. We also we're going tomorrow for our third public health emergency mission due to calamities and the rain. We started in the extreme southern Bahia, Minas Gerais, and we have a team now since yesterday in Rio de Janeiro, and tomorrow we are going with all the infrastructure that we could be supporting. And such a response team for such a disaster is to support the health professionals. So in Petrópolis, we're going to set up an operational center to receive the nursing professionals, because they are also victims of this disaster. Lots of times they are forgotten and treated as regular people, but they are reflecting deeply in the health network. And I have to say also that about our Solidarity Nursing, Enfermagem Solidária, which is a great program organized by Professor Adarzai with more than 170 volunteers and professionals, professors, doctors, and experts of mental health, that worked in the pandemics and are working now with the professionals and the family members that were impacted by the floods in Petrópolis, taking some support, psychosocial support to all of them. And we're also going to set up in Petrópolis with the Enfermagem Solidária, not operating 24/7, but 12 hours a day, morning until the early beginning of the night. Okay? Thank you so much for the invitation to be here. I'm on social networks with this username. My institutional email is eduardo.souza@cofam.gov.br. I'm sorry for the time. I exceeded a bit my limit, but we're here available to any questions and comments you might have. Dr. Eduardo, thank you so much for your contribution for this event. Unfortunately, due to the delay in time, we are not going to be able to open for a Q&A session now, but our audience and the public has your email available, and they can make a direct contact with you. On behalf of the organization of the event, we'd like to thank all the participants, all the speakers, Professor Carla Ventura, and I'd like to remember that this event will continue on Friday, tomorrow, the 18th, starting at 9 a.m. in the same digital platforms. I wish everyone a good afternoon and see you tomorrow. See you tomorrow, everyone. Don't miss it. Bye-bye. See you.